Yeah, and we are live. Good evening, everyone. Welcome to the 14th chapter in the second series of masterclasses brought to you by the Academic Council of IASO. I welcome our President, Dr. Rajendra Truprani, to kindly deliver the welcome address for today.
Good evening, all IASO members, senior colleagues, and students who are attending this program today. So today is a very interesting topic on hypopharyngeal cancer. Not only it's a difficult cancer to treat, and the oncological outcome, and even in the later stages, the functional outcomes are difficult to accept. It's not acceptable by most of the patients, and the oncological outcomes are also guarded. So let us see how the discussion goes today with the examiners and the two examinees. We have got two brilliant head and neck surgeons today. Dr. Rtog Trial, of course, from Delhi, AIMS, and is the professor of head and neck surgery. And Dr. Gauri she is a professor at TMH. And Dr. Chandrasekhar from, of course, from Hyderabad, Indo-American. So let us see how the examinees, the students, they fare, and I wish all the best to the students. Over to you, Srijan.
Thank you, sir. The examinees for today are Dr. Iman Rumani, who's a resident in Department of Surgical Oncology at Chittaranjan National Cancer Institute, Kolkata, and she's being joined by Dr. Quresh Sadriwala, who's at Omega Hospital, Hyderabad. Both are second-year residents. A few housekeeping rules for the session. The first hour would be a mock examination in which we expect the examinees to give to-the-point answers to the questions being asked. It's never expected that you would know everything, so there's no harm in that mentioning that if you don't know something, it saves us time and it maintains the flow of this online webinar pattern. Our examiners do have the habit of giving hints to you. It's up to you to catch that and progress. To our dear examiners and moderator, we request you to allow both the examinees to participate and address them by their name so that they know who is expected to speak. And in interest of the online viewers, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered by them. For our participants, we see some senior ISO members in the group. Thank you for joining in, and please post in your inputs in the chat box. They are highly appreciated. And for the residents, it's a unique opportunity to clear all your doubts related to the subject. Please use full use of this opportunity. As for the timekeeping, I'll remind the moderator at 45 minutes, and at the conclusion of case discussion which would be at 60 minutes. Over to our moderator for today, Dr. Chandrasekhar.
Very good evening to all of you. Without basically wasting much of time, let us progress on to the cases. So we do have actually scenarios from different kinds of hypopharyngeal malignancies. Of course, we know that 95% of the malignancies are squamous, but let us just start by, case by case. So there are two examinees. How can I call them? Iman?
Yes, sir.
Is that? Okay.
Yes, sir.
Yeah, other one is Quresh, right? So let us go by first case. See that there is a 39-year female presented to the OPD with foreign body sensation in the throat since last 2 months, and no other complaints, no other comorbidities. So what do you basically expect the patient to be asked again for the detailed history? Can you say, Uman, what exactly further history you would like to know?
So I would like to know if the patient has any difficulty in swallowing. And also if the patient is having any difficulty in breathing, if the patient is having any pain in the ear, if the patient is having change of voice, and also I would like to ask about the addiction history yeah.
Dr. Gauri, someone can please take the lead further.
Sure. Iman, that's nice the way you said it. Now tell me, if a patient comes with a foreign body sensation, let's say it's an OPD. Now, of course, you know we are talking about hypopharyngeal cancer. So what do you think is the cause of foreign body sensation in a patient's throat? What are your differential diagnoses when you see the patient? Your history will have to be depending on what all are your differential diagnoses. So what is the commonest cause of a foreign body sensation in the throat?
Ma'am, mostly viral infection, sore throats are usually common.
Correct. Very good. Can it be a
And
foreign body?
Yes, foreign body per se would cause a choking sensation, ma'am. Not a foreign body sensation per se, ma'am.
Okay. So a foreign body, it's called a foreign body sensation because the foreign bodies give you that sensation. So,
Foreign, yeah, yes, sir. Yes,
so
ma'am.
if you have, let's say, a bone that's stuck in your throat, that can give you a foreign body sensation. So if with just this much history, you must understand that you must rule out the common causes of the symptom. Whatever is your common cause, so your viral infection, you could have just asked for history for any fever, or if the
Yes,
patient
ma'am.
has a running nose or a sore throat. So if,
Yes,
if the only thing the patient comes to you with complaint of a foreign body sensation, please look at the more common things first before jumping onto hypopharyngeal cancer.
yes, ma'am.
The second thing you said was, you said difficulty in swallowing. Would you want to further ask any details about this difficulty of swallowing, or just there's a difficulty of swallowing, yes, no is enough for you?
No, ma'am. I would like to know whether she has difficulty in swallowing to solids or liquids, ma'am.
Very good. Anything else? Anything between solids and liquids? Are you aware of grades of dysphagia?
Yes, ma'am.
Go ahead, tell me the grades of dysphagia. And why is it clinically? Everything is clinically relevant. This is not just for the exam.
She's having difficulty. Yeah, there are 4 grades of dysphagia, ma'am.
Very good. Tell me.
First is the patient not able to tolerate normal diet. The patient's grade 2 is the patient's able to tolerate soft semi-solid diet. Third is the patient is able to tolerate liquid diet. Fourth is the patient not even able to swallow the own saliva.
Yeah. So tolerate is as in swallow. So the better word
Yes,
would
yes,
be swallow. No issues. So you're absolutely right. So those are the 4 grades of dysphagia. So your history of dysphagia has to have which grade of dysphagia this patient has. Kuresh, you want to tell us how the grade of dysphagia is going to help us?
Ma'am, it will, the grade of dysphagia will help us localize if it is a malignant or benign. If there's more liquids to solids, then it is more towards and the duration, it's more towards a benign pathology. And if it's more towards solids, then it can be a more malignant pathology.
I don't think I agree with that actually, Kuresh, because I'm not sure that by, even with malignancy, you can have dysphagia to liquids. You can have any kinds of dysphagia. So I don't think I agree with you on that point that, it determines malignancy. Anything else that dysphagia is going to help you in? Is it important for you to manage your patient to know what kind of dysphagia they have?
Yes, ma'am.
Yes, ma'am.
Yeah. Also, will it help you to understand if this is a malignancy, if it's a stricturous type of malignancy, or would that have any effect on your treatment?
Yes.
Okay. So that's why grades of dysphagia. So when you talk about history as dysphagia, it's not just dysphagia. There are 3-4 things. One, you have to talk about the duration of dysphagia, how long it was. You have to talk about the grade of dysphagia, whether there was a gradual change from grade 1 to grade 4. That's very important for you to know. Okay. So that's with history of dysphagia. Okay. So just finding out if the patient can swallow or no is not important. Dr. Thakkar, you want to ask some questions?
Well, from my perspective, I would totally agree that it would be jumping the gun to suddenly think of hyperpharyngeal cancer on just this history. I would have asked for dyspepsia and reflux before I even moved forward. Yes, all the other causes. With regard to dysphagia, I tend to classify them into 3 ways. Dysphagia which occurs because of pain on swallowing or dinophagia, dysphagia which occurs because of obstruction, and dysphagia which occurs because of aspiration. And of course, it's quite easy on history to tell which one it is, and all of them have a very different DD. So it just helps to categorize how to move forward. So let's go on.
Yeah, go ahead, sir. Go ahead.
No, I said you can go on. I'm done. Yes.
Okay, yeah.
So that was your first history of dysphagia. The second thing you said was pain. You said odynophagia. And
Yes, ma'am.
you said earache. What is this earache? Can you tell us why you asked a patient who has a foreign body sensation for earache?
Ma'am, if it is a pharyngeal based lesion, if the patient is having a pharyngeal based lesion, there'd be a referred pain to the ear through the auricular branch of the vagus nerve, ma'am.
Very good. So what does that signify?
Infiltration of the superior vagus, mostly the posterior pharyngeal lesion, most likely, and it is infiltrating the internal branch of the superior laryngeal nerve or infiltrating the vagus nerve, ma'am.
So basically what it
This is
signifies
local
is that you're dealing with advanced malignancy.
advanced disease, yes, ma'am.
Okay, so if you have earache, then you know that you're probably dealing with advanced malignancy. So you talked about dysphagia, you talked about any other, what other history?
A change in voice, ma'am.
Change in voice. Okay, so what does change in voice signify?
Ma'am, if there's a change in voice, it either signifies that it is an advanced disease involving the laryngeal nerve, or it is an advanced disease, it is involving the vocal cords, which is causing the change in voice, ma'am.
Okay. After change in voice, what was your next history?
Difficulty in breathing, ma'am.
Difficulty in breathing. Okay, what does that signify?
Ma'am, if it is an extensive lesion or if it is extending into the larynx, there will be a possibility the patient would be having a difficulty in breathing. Or if it is extending cranially also, ma'am, then patient would be having a difficulty in breathing, ma'am.
Cranially as in?
If in case posterior pharyngeal wall involving cranially to the to the base of the tongue with the nasopharynx involvement in it.
Right. So is there going to be a difference in the breathing difficulty if it's involving the oropharynx versus the larynx? Okay, no issues. Anything else? Any other history? I think Dr. Thakkar gave you a hint.
History of cough, aspiration, reflux, ma'am.
Reflux, correct. Cough and aspiration. How will you ask for that history?
Whether the patient is having cough after consuming food, when the patient is having cough, history of coughing.
If so, does aspiration happen? Is that the way you would ask history after eating food? Is the patient pardon?
After lying down, the patient sits up and then the patient experiences cough.
Suresh, any suggestions? Is it on food that we ask for that history?
Ma'am, it can be.
No,
go ahead, Kuresh.
Hello.
Yeah, go ahead.
Yes, ma'am. For reflux, we need to ask if there is any, after having food, if he's having any burning sensation, any change of taste in the mouth, which is causing cough.
Okay, so Iman, I'm not sure I got you right. So are you asking history of cough for reflux? Is that your aim to rule out reflux, is it?
Yes, ma'am. Okay. Reflux, aspiration due to reflux, ma'am.
Oh, okay. So is that what's really worrisome for us, or what is the type of aspiration and the cause of aspiration that we are looking at if we think this is a malignancy?
Ma'am, it will be more, the patient would not be able to swallow swallow his own saliva. So there'd be possibility of aspiration of saliva.
So what
if it is
the aspiration that worries you? What is the aspiration that worries you? And let's say a pyriform sinus cancer patient, and this patient, are you worried about reflux related aspiration? Okay, so let me just quickly give you this. So in hypopharyngeal cancers, if for any reason you have a fixed hemilarynx, you have patients who have what is called a dysfunctional larynx. So
yes,
one of the functions of the larynx is to prevent any food or water going into the respiratory tract. So
yes,
I think it's very important for us to know if this patient has a functional larynx or no.
Okay.
So what are the functions of the larynx that you need to look for?
Ma'am, this speech, swallowing, phonation, and airway, ma'am.
Okay, so airway, speech, swallowing, as in each patient should not aspirate. So you spoke
Aspirate,
about
yes, ma'am.
breathing, so that was a good thing you found out. Why is it important for us to know if the patient is having aspiration or not?
Ma'am, aspiration pneumonitis.
Okay, so a patient may get aspiration pneumonitis, so you have to look after this patient. If the patient comes to you and the patient is having aspiration, then he may get pneumonitis before you start your treatment. Yes. Right? So that is why you need to know whether the patient is having aspiration or no. So how will you find this aspiration? What is the, we are still on history only.
Yes. Ma'am, if the patient is complaining of coughing, if the patient is having fever, if the patient is giving a history of not able to swallow.
Want to classify this coughing little more? What kind of on taking what? Okay, let me just clear this and go ahead. So you have to look at aspiration to liquids. Okay, yes, that's the commonest form, not to food. So you have to ask the patient, when the patient drinks liquids, does the patient have cough? That's the aspiration you're really worried about, to know whether this function of this larynx is, if the patient is coughing when the patient is taking food, then it's a very far gone case. So for you to make out subtly whether the patient is having aspiration, you have to ask whether the patient is having aspiration to liquids. It's, I think, probably one of the most important questions in history if you're suspecting hypopharyngeal cancer. Okay, aspiration to liquids. Yeah, Dr. Thakkar?
No, let's go on. Let's move forward.
Yeah.
I would have asked for loss of weight. If a patient's having dysphagia, you ask for loss of weight. But let's move forward.
Dr. Iman, you said about breathing difficulty, right? Probably to make sure that, see, there would be two reasons for this kind of, or any kind of lesions which can lead to breathing difficulty. One is the obstructive lesion, where there is a kind of proliferative component which is in the hypopharynx or in the supraglottis, which can really obstruct the airway and can lead to breathing difficulty. Or if there is a dysfunctional larynx by means of the nerve which is infiltrated, or hemilarynx which is fixed, or both sides larynx, if they are fixed in the sense by involvement of the larynx, or the innervation of the muscles, which can also lead to breathing difficulty because of the immobility of the vocal cords, right? So these are the two reasons. See, I mean, the sense the etiology might be different, but these are the two reasons which can really lead to difficulty in breathing. Okay, so let's move further. And what clinical examination you are going to do? Probably I would ask Dr. Quresh.
So first we'll on clinical examination, we'll palpate the neck. We look for any lymphadenopathy. Then we would do an indirect laryngoscopy just to rule out if any pharyngitis or any other presence of any other inflammation or any pathology is present.
Okay. Shravan, can you further go on to the next slide? Yeah. You can see that there is a video laryngoscopy which is playing in front of you.
Yes, sir.
So can you comment on that? As you asked, we did the video laryngoscopy.
Yes, sir. So on the video laryngoscopy, we can see some ulcerative thickening in the just at the arytenoids, actually. Or,
okay.
Yeah. There's some edematous, and arytenoids also edematous.
Okay. Anything else you would like to see in that?
So pyriform sinuses, if to see the lower extent actually.
Right.
And if possible to do a biopsy.
Okay. And before biopsy, are you going to see anything else in that apart from the ulcer?
The vocal cords
yes,
mobility.
Yes. So over to Alok, sir.
So in the neck examination, especially if you're worried about dysphagia, it's not enough to just look for lymph nodes. Do palpate for lymph nodes, also palpate the thyroid gland. And you would have to demonstrate to me that the laryngeal crepitus is something that you have thought of and looked for.
So actually, I didn't think for laryngeal catheters because it was only foreign body sensation. For I assumed it to be for larger tumors we might be able to see for laryngeal catheters.
So I think it's quite likely that even in this tumor, the crepitus may be absent.
Okay.
The crepitus is basically the rub of the posterior surface of the cricoid cartilage on the vertebrae. And if there is any intervening thing between the posterior surface of the cricoid cartilage and the vertebrae, then you tend to not have the crepitus felt. And in this particular situation, it is quite possible that it would not be felt because you can obviously see a tumor. So you should be looking at it. You should also be looking for laryngeal expansion. So if there is an advanced tumor, then of course it would invade the thyroid cartilage and you would get some asymmetry in the larynx and laryngeal expansion. You should be looking for laryngeal tenderness. You should be looking for fullness of the thyrohyoid membrane. High lesions of the hypopharynx will cause fullness there. And another thing that is happening here, of course, you're presupposing that this is a patient where there's a high index of suspicion for hyperpharyngeal cancer, that if you have a lady, this is a lady, isn't it?
Yes.
And this is a lady who's not too old and doesn't have too many addictions, then of course the common cause for hyperpharyngeal cancer turns out to be Plummer-Vinson syndrome.
Yes.
So you should be looking for Plummer-Vinson syndrome when you get a lady with dysphagia. Even otherwise, a lady with dysphagia can be having a laryngeal web. If you get a thin-billed lady with dysphagia, look for koilonychia, look for anemia, iron deficiency anemia, maybe an atrophic tongue. So all of these things, of course, if you haven't mentioned, it's if you would have mentioned, it would have got you a much higher mark. That's all I can say. And if you now describe the lesion, describe it again for me, I can understand that you're not focused only to head and neck cancers. But I would say that both the arytenoids are mobile and fairly normal. And you see this central lesion in the post-cricoid area, retroarytenoid and post-cricoid. It seems to be going down, of course. Yes, the cords are mobile, which basically indicates to you that the lesion is probably not very deep, because the way a post-cricoid lesion causes cord paralysis is by infiltrating the posterior cricoarytenoid muscle, which is on the posterior surface of the larynx. And in this instance, it does seem that it is not involved because the cords are mobile. The lower extent of the lesion is not seen. Pariform sinuses in general seem normal.
Yes.
How would you proceed further to evaluate this patient?
So after taking a biopsy, we would like to do a contrast enhanced CT scan of the neck.
So we would generally like to do radiology before doing a biopsy. That is ideal.
Yes.
You could do it either way, but once you do a biopsy, there's going to be edema,
Right.
and radiology may be a bit of a problem. So better to do it before than after. Both are right answers, but better to do it before. Better to do radiology before than after. What else other than radiology?
So blood investigations, like you said, to rule out anemia, iron deficiency anemia.
One of the major things we need to look at is lower extent of lesion.
Yes.
We have not yet been able to find lower extent of lesion, and that would have to be done either by radiology or by endoscopy. So you need an endoscopy which goes beyond the lesion and can assess below. And also with the hypopharynx, because there is risk of second primaries in the esophagus, what was previously talked about as KIP mets, but is now probably more likely to be second primaries. So you should do an esophagoscopy ideally for all your patients. So in our workup, this patient would obviously get an esophagoscopy and radiology. Anything else you want to tell me for metastatic workup?
So CT chest.
Okay. Dr. Gauri?
Yeah, so I would agree with what Dr. Thakkar has said. I think your clinical examination has to follow a proper pattern. If you don't follow the proper pattern, you will, one, for your exams, miss out on a lot of points. So your clinical examination, I would say, was not up to the mark at all. So even if you don't feel that this patient requires to see, you need to see laryngeal crepitus, it has to be part. You have to say there is no laryngeal crepitus. Okay, there is no chance. So if you keep, for all cases, let's say it's a thyroid, let's say your clinical examination has to have 10 points. And they have to be there. You have to say it's not there if you don't see it. You know, that way you will complete. So whenever you all should make little templates. So for hypopharyngeal cancer, what Dr. Thakkar told you, all those points have to be there for any case of hypopharyngeal cancer. It may be there, it may not be there. It will help you diagnose many things by your clinical examination. And frankly, even in the clinic, all of these things are very important. It will help you, it will give you an idea whether this is an advanced cancer, whether it's hypopharyngeal cancer or not. So please have a template ready, and all points are absolutely important. So just saying neck nodes and this thing, it doesn't work that way. Laryngeal expansion, all of those points have to be absolutely mentioned. I don't know if you mentioned doing an indirect laryngoscopy. Did you say you would do an indirect laryngoscopy?
Yes. Yes,
okay,
ma'am.
you said you would do an indirect laryngoscopy. Yeah. So an indirect laryngoscopy will have to form a part of any of these examinations. And you were a little reluctant in trying to do a CT chest. Would you want to do, or would you depend it on, you know, like a small post-cricoid cancer patient does not have lymph nodes, or what, or do you do it in every patient?
I would do it in every patient actually.
Right. So there is no question about it that as of today, especially in hypopharyngeal cancers, why in hypopharyngeal cancers? It's important even more to do a CT chest.
Ma'am, because we need to, as mentioned, aspiration pneumonitis to rule out.
Is that the reason why you would want to do a CT chest? What is your main reason in this?
Metastasis.
Cancer? Correct. So if you all are aware of there's some few peculiarities of hypopharyngeal. They've got highest rate of distant metastasis. Right. Okay, other than let's say anaplastic thyroid cancer, in the head and neck, highest rate of distant metastasis are of hypopharyngeal cancers. Okay, and the commonest site of a distant metastasis would be
lung.
Right. Okay. So in all suspected hypopharyngeal cancers, you should do a CT neck and thorax. Okay. Any other modality? You can use other than CT neck and thorax?
What is the gold standard for metastatic evaluation today?
PET CT.
Great. So this is probably the one place where even doing a PET CT is okay. Okay, so a PET CT is a good modality. How would the PET CT score over CT scan only?
Ma'am, it will help pick up any other second primaries and
very good.
Nodal diseases.
So second primaries is a good question, good point. Nodal disease. Anything else? Ivan, you want to add in? Besides second primaries and nodal disease, anything else?
Occult nodal metastasis, ma'am.
Occult nodal metastasis. Is PET CT good for occult nodal metastasis?
Ma'am, if there is a size discrepancy on CT scan or MRI, PET CT scan may pick up occult nodal metastasis.
Okay. What about you, Quresh? You think small little metastasis, PET CT?
No, ma'am.
Yeah. So PET CT is actually not a great modality for very, very small occult metastasis. Okay. So it's not a very great modality. So that's not why we want to pick up occult metastasis. What about metastasis in parts of the body other than the lung? Would that be helpful as compared to a CT chest?
Yes, ma'am.
Yes. Okay. So so if anyone asks you what is the advantage of PET CT, as you said, to pick up any other nodes or to pick up a second primary, and the third thing is non-pulmonary metastasis. Okay. So these are the three important things why a PET CT, and hypopharyngeal cancers also have bone metastasis. So probably in this group of patients, PET CT also is a good option. Okay. Upper GI scopy, you said you would do. What all information would you want on an upper GI scopy?
Ma'am, first if we can find the lower extent of the disease, if the scope is passable into the pharynx and esophagus, if there is any other lesion in the esophagus,
is there anything, is it important for you to know the distance, the amount of distance that the postcricoid and the esophageal involvement is present? Is that of any importance?
Yes, ma'am.
Okay,
Oh.
what importance?
For planning of surgery, as in till what extent, if it is involving the going into the esophagus, then the planning and management might change.
Very good, very good. So these are the things that you need to know on upper GI scopy. Okay. I think there are 2 or 3 things that have been put by some people on the chat box, and I think one of the very important things that you have to mention in your clinical examination, especially with hypopharyngeal cancer, is the ECOG status. Okay, so this is probably the one cancer where it is absolutely vital to know if this patient is hale and hearty or no, and so the ECOG status has to come, or PS status, performance status, or ECOG status. It is just a must in all malignancies, in fact, but hypopharyngeal cancers especially, you must have the ECOG status mentioned as the first thing you mention in your physical examination. Okay. Dr. Thakkar, anything else?
No, thank you. Can you interpret the CT scans for us?
Dr. Thakkar, nothing actually significant here, because except a minimal thickening here.
Right.
Absolutely, there are no lymph nodes, as well as there is no like extent of the disease or anything cannot be commented, because it's very thin lesion probably.
Yes, and it doesn't seem to be going too far down, because the post-cricoid space, the pre-vertebral space is not expanded.
Absolutely.
Except on the first cut. After
Correct.
that, it actually seems quite so. At least radiologically, there doesn't seem to be very significant lower spread. On an endoscopy, if it's different, I don't know. But all said and done, radiology does seem to indicate that tumor is not going too far low.
Yes. The other thing, what Dr. Kuresh said, PET CT scan, one of the important investigations for the hypopharynx. As Dr. Gauri also pointed out, basically the second primaries in the esophagus are very common, especially with the PV syndrome associated malignancies. So in the post-cricoid, if it is little extensive, our scope also cannot be negotiated very well, so that we'll be able to pick up, especially by doing a PET CT or a CT chest, any second primary in the area, because your treatment totally differs once you know that there is some second primary in the other part of the esophagus. So can we move on to the...
Yes, of course.
Yeah, go ahead, Dr. Thakkar, go ahead.
No, go on.
No, nothing, go ahead.
I was saying move on. Let's move on. So
Okay.
yes, management. So which one of you wants to comment on how we should be managing this patient?
Dr. Iman, you can actually comment on that.
So I would like to know the performance status of the patient.
Biopsy has been done. Yeah, biopsy has
yes.
been done. It was a squamous cell carcinoma, well differentiated. And yeah, swallowing, as you said, absolutely, she's able to swallow except a foreign body sensation. There was nothing, no difficulty as such. And performance status is absolutely good.
Sir, I would like to stage the disease. If the staging is, if the patient is early stage 1 or 2, I would like to give definitive radiotherapy for this patient, sir.
So stage the disease. What is the stage that you have? You have the radiology, you have the clinical picture in front of you.
Sir, it is T2N0, M0.
So radiologically N0.
And M0. And T1 or T2, yes, sir.
And radiologically, why do you call it T2?
Sir, I cannot comment on the extension of the size of the tumor here. And since I cannot comment on the size, it can be either T1 or T2, but it is involving only one subsite. So it can be T1 still, sir.
So what is T3 in hypopharyngeal cancer? What is T4?
T3 in hypopharyngeal cancer is if it is more than 4 centimeter, or if it is extending to the esophagus. Yeah, again, if it is extending to the esophagus, or if the hemilarynx is fixed, sir, in T3.
So the hemilarynx is not fixed. Hemilarynx is not fixed. And
yes,
the
sir.
impression we have both clinically and radiologically, that's certainly less than 4 centimeters.
Yes, sir.
It doesn't seem to be extending to the esophagus. What is
yes,
T4?
So T4 is T4A and T4B, that is moderately advanced and local, very advanced disease. Moderately advanced disease is where it is involving the thyroid thyroid and cricoid cartilage, hyoid bone, thyroid gland, and yeah.
So it doesn't seem to be involving any of those.
No, sir. So it is not T4, sir, T4A or T3 in fact.
So I would like you to tell me that it's not T3 because the cords are mobile and because the lesion is small, and I would like you to tell me that there is no cartilage erosion. So on this basis, I stage this as T2. I could even stage this as T1. Could it be T1?
Sir, it can be T1, but the esophageal involvement, whether the esophageal involvement is present or no, I can't comment upon till the time I don't get an endoscopy.
So the way forward would be for you to say that I presume an endoscopy was done, and may I know what the findings were? Was it involving the esophagus? You ask me that question, I'll give you the answer, and then you say whether this is T1 or T2, because you have to demonstrate to me that you have thought this through and you have staged your lesion.
Yes.
So let's say you have staged this as T1 and 0. I can understand that you have some doubts as to whether it's T1 or T2, but it's certainly early stage disease. Logically, there's no evidence of extensive size enlargement. There's no evidence of cartilage involvement. There's no evidence of cord dysmobility. So this is early stage disease, probably T1, maybe T2. Either way, what is the treatment?
So I would like to go with definitive RT, sir, for this patient. Definitive radiotherapy.
So you'll have to elaborate on that.
Sir, definitive radiotherapy, 70 gray, 30 fractions in 6 weeks, sir. 35 fractions in 6 weeks.
Well, we
70 gray, sorry, sir. Yeah, 70 gray to the primary side and 45 to 50 gray to the nodal areas, sir.
You want to irradiate the nodes?
Yes, sir.
Why?
Because there is a very high percentage of occult nodal metastasis in patients with hypopharyngeal cancer, sir.
So basically, you're saying to me that this is a lesion which is early stage. I would to treat this patient. I think there's an opportunity for organ preservation with appropriate treatment. And based on that, my choice would be to go in for radical radiation.
Yes.
And with radical radiation, 70 gray by standard fractionation. That's what you will have to state to me. It will take 7 weeks to treat this patient. And then you will also have to state to me that in this particular patient, hypopharyngeal cancer is very high risk for lymph node mets, occult lymph node mets to both necks, even in early stage disease. So hypopharyngeal cancer, irrespective of stage, I do suspect occult lymph node disease, and I need to give elective nodal radiation to both necks.
Yes, sir. Bilateral.
Because they are at risk.
Yes.
And yes, I would give at least 50 gray. But if you said 45, then I can understand that institutional protocols can be different.
Yes, sir.
So very good. Dr. Gauri?
Role of surgery?
Ma'am, in post-cricoid area, since it is, we would definitely want to go for organ preservation. So organ preservation and we would assess if organ preservation can be done with non-surgical methods or surgical methods. Non-surgical method is indicated here. Surgical method, ma'am, can be done because because post-cricoid region is not accessible for non-surgical surgical methods. That's why I would not want to do, ma'am.
Correct. So that's the perfect answer because it's a post-cricoid malignancy. What if it was a pyriform malignancy, a T1 and 0?
Ma'am, had it been a pyriform fossa region, if the patient's performance status is good and the patient's pulmonary function test is good, pulmonary function reserve is good, then I would, and if the surgeon is has clinical experience in doing laser, transoral laser microsurgery or transoral robotic surgery, yes, ma'am. And also, if it also depends on the level of the pyriform fossa involvement. If it is superficial pyriform, superficial aspect of the pyriform fossa and not the deep and the apex, ma'am.
Right, you're absolutely right. So if those are the exact reasons where you will do surgery. That's a good answer. Okay, but for this patient, more often than not, we will take up radiation.
Yes.
Yeah.
Any thoughts from you? We will have to share.
Yes. Video. No video. Yeah. See this. There is a similar kind of small lesion. what Dr. Gauri has pointed out. Are you able to see that, Dr. Iman?
It's a
Yes, sir.
beautiful lesion. It's a beautiful lesion.
Yeah.
Yeah,
So,
piriform fossa lesion.
so would
Yes.
you consider any kind of surgical treatment, organ preservation for this kind of lesions?
Sir, since submucosal lesion involving the left aryepiglottic medial wall of the left piriform fossa, yes, I would, sir. Transoral robotic surgery can still be considered for this patient, sir.
Okay, good. Transoral, either robotic or laser, whatever the
microsurgery.
expertise is available with you, you can do it.
Yes.
Next slide. Just to finish the discussion, next slide. Shravan, can you go to the next slide? The same patient, actually, see, if you look at the scan where there are no lymph nodes as well as not really big lesion.
Yes, sir.
Go back, Shravan. No. Let's go on there. Okay. So that kind of small lesions, you can consider surgical treatment also as an option, right?
Yes, sir.
What will happen if you really consider for a laser or robotic surgery for the case which we discussed in the go back show? Yeah, this particular patient, if you really consider, what can happen?
So we would not be inadequate exposure primarily, sir. The exposure would not be adequate for complete resection. There'd be chances of margin positivity, sir. And
Anything else?
So stricture formation.
stricture formation.
Stricture is one, absolutely true. Anything else? See that particular lesion which is basically presented behind the arytenoids.
Yeah,
Enter
it is
arytenoid
close to
area and arytenoids.
yes,
Yeah. If you resect, what will happen?
Sir, there's a chance of damage to the arytenoid or the intrinsic cricoarytenoid muscle. So there would be a possibility of later vocal cord immobilization. The mobility of the vocal cord would be hampered later, sir.
Absolutely. It will become dysfunctional larynx. Absolutely
yes, sir,
dysfunctional larynx.
Yes.
Okay. Shravan, go to the next case. Can we go on to the next case? Or?
Yes, certainly, sir. We had a good discussion on this one. Excellent case here, and I was especially taken up by the other patient that you showed here, an excellent selection of another patient with a T1, T2 lesion of the piriform sinus where surgery was an option. So yes.
Can I ask a question, all of you?
Sir, of course.
So, Iman and Quresh, when you say you'll give definitive radiation for the post-triggered lesion in the first case, what would be your field of radiation for the nodal basin?
Bilateral from
What level of nodes would you cover with radiation?
level 2, 3, 4, and 5, sir.
One more
And
level.
retropharyngeal nodes, sir.
And one more level.
Retropharyngeal and level 6.
Pre-treated.
Level 6. Can you go ahead, sir?
Yeah, go ahead.
Yeah. Dr. Quresh, can you look into that second case? You can read out and probably, yeah.
Yes, sir. 55-year-old male comes with complaints of difficulty in swallowing since 3 months and a left neck swelling since the past 2 months. He's a known diabetic on treatment since 5 years.
Sure, next. Yeah.
So,
I think history-wise enough. The same thing what we discussed.
yes.
So examination-wise, absolutely enough. Nothing much to do. See the lesion now and describe it, and probably you can stage once you look at the scan as well as endoscopic image. You need to describe all the possible findings.
Yes.
Both positive and negative findings.
Yes. On the video laryngoscope, there is a big growth involving the valleculi, the epiglottis on the left side, the piriform sinus, and just at the arytenoids, the right vocal cord movement is present. There is the left hemilarynx is fixed. and there is pooling of saliva also.
Anything else?
Suresh, I'll ask you a question, quick question. Can you
Yes.
define the subsites and give me their definitions of the hypopharynx? What are the subsites of the hypopharynx?
So, ma'am, posterior pharyngeal wall, the pyriform sinus, and postcricoid. Pyriform sinus is a conical shape. It is the lateral is the thyroid membrane. Medially is the lateral border of the array-epiglottic fold, and apex is and formed by the apex. Posterior pharyngeal wall extends
How
from.
low is the apex? Till where is the apex of the pyriform sinus?
It goes beyond the postcricoid actually at C4 level.
So it's at the lower border of the. If you look at your TNM staging, no, always
Yes,
if you look at your AJCC 8th edition, they will give you the exact definition of each of these sites and their boundaries. Okay, so have a look at what the boundaries of all of these are. So the pyriform sinus goes all the way up to the lower border of the cricoid cartilage.
Yes, ma'am.
What about the posterior pharyngeal wall?
Posterior pharyngeal wall.
From where to where does it form part of the hypopharynx?
Beyond the epiglottis till the at the upper border of the cricoid, posterior pharyngeal.
So it's not beyond the epiglottis. It is actually at your lower end of the vallecula or your area epiglottic folds. Okay, that's where your posterior pharyngeal. Above that, it forms part of the oropharynx. And then
Oropharynx.
above that, part of the nasopharynx. Okay, so that is where your posterior pharyngeal wall. And what about your postcricoid? What is it defined from where to where?
Upper border of the cricoid going till the upper esophagus.
Okay, till the upper esophagus. Okay, okay.
So when you look at this patient, you see some pooling in the contralateral pyriform sinus. What does that
Yes.
indicate to you?
So dysphagia, as in he's not able to swallow his own saliva.
It indicates that there is likely to be
Complete of.
a little bit lower down too.
Yes.
Right, so let's come to the types of scopies that you can do. Have you heard of a direct laryngoscopy? Do you do it? What is a direct laryngoscopy?
Direct laryngoscopy is when during what they do during intubation, as in
Okay.
directly visualizing it.
Okay. Do you know direct laryngoscopy being done for hypopharyngeal cancers to map out the disease?
Sorry, ma'am.
Do you know direct laryngoscopy being done for hypopharyngeal cancers, not during intubation?
I don't know, ma'am.
Okay. Iman, any idea about direct laryngoscopy?
Direct, yes, ma'am. There is it is done to before the patient's been if the patient's being planned for surgery, we can do direct laryngoscopy to assess the extent of the tumor, extent of the lesion, and extent of the tumor, and also
How is direct
ma'am,
laryngoscopy done?
sorry, ma'am.
How is direct laryngoscopy done?
Ma'am, there's this suspensory direct suspended suspension laryngoscope that is inserted and can visualize the larynx in the laryngopharynx, ma'am. And also with the laryngoscope, there's this direct laryngoscope, rigid laryngoscope, through which you can visualize the entire larynx under sedation, ma'am. If in case we need to take a biopsy through with the help of direct laryngoscope.
Right. So
And also
biopsy
to
is
assess the
not that important, but yes, it is done under general anesthesia and is
Yes.
done with a rigid direct laryngoscope.
rigid.
So when do you think you need to do a direct laryngoscopy over video laryngoscopy in hypopharyngeal cancers? Do you need to do it at all? Do you not need to do it?
Yes, ma'am. If in case the patient is being planned for surgery, we would like to assess the extent of the tumor lesion. So we want to do a direct laryngoscopy.
So what extent do you need to see? That you can't see on a video laryngoscopy. Why put the patient under anesthesia? Just because you want to operate?
Ma'am, the piriform sinus becomes more prominent if the patient is under sedation. If the patient is not under sedation, the piriform sinus collapses, and so the lesion is not clear. Sometimes it can be missed.
Right. So I'll just put it for you. So the thing is, direct laryngoscopy is done when you are expecting that the lesion, you can't see the lateral borders of the lesion well. Okay. So with a video laryngoscope, what happens is, as you said, the piriform collapses. The posterior pharyngeal wall comes, you need what is either you need what is called a transnasal endoscopy, where you have insufflation available.
Yes, ma'am.
If you have insufflation, then that will move aside and you will be able to see all the walls of the piriform sinus. Now, if you want to plan whether this patient requires reconstruction, whether this patient requires any sort of other type of reconstruction that you want to do, to see the lateral and the posterior extent. These are the two extents of whether it's involving the posterior pharyngeal wall and how laterally it's coming. So these are the two really critical things that you may not see very well on a video laryngoscopy. So a direct laryngoscopy, how to do a direct laryngoscopy should be in your armamentarium whenever you're dealing with hypopharyngeal cancers. Okay. So direct laryngoscopy is something that you must say, especially in this kind of a tumor where you are unsure what is happening on the lateral wall and in the apex of the piriform. These are not areas that a video laryngoscope can go through without insufflation.
Yes. So next slide, please.
So do you want to see the imaging? Do we have imaging? Yeah. Okay.
And we have the clinical next staging. What is the clinical stage? I mean, I know we have already discussed what are the...
No, clinical left neck nodes are positives.
Okay. And crepitus is present, I suppose. So
Okay,
great, we have the CT scan here.
Yes, sir.
And you want to tell me what you see on the scan?
So on the scan, we can see the lesion on the left side, hypodense lesion, and the lesion is extending into the thyroid cartilage and also into the strap muscles. So there's destruction of the thyroid cartilage, and it is extending upwards into the valleculi, the epiglottis.
Yeah.
You want to describe anything else? Is it in the laryngeal framework or has it come out of the laryngeal framework?
Out, ma'am. It has destructed the cartilage.
Yeah. Yeah. Is that the only area it's coming out from? What is the other area of concern? Just look at those 4 things that are there on the other side, not the one that's moving maybe. Look at the second one on the top. Is there any concern there for you? Do you think you need to report that or?
It is going to the prevertebral fascia also. It's posteriorly.
It seems like there is a posterior involvement.
Yeah.
Anything else besides the prevertebral fascia that will worry you there?
The vessels close to the vessels actually. So encasing, it's not encasing them, but it is close to the vessels.
Which vessels?
The carotids.
Okay.
Left carotid.
It's close to only one carotid. So it is close.
Yeah.
So when you're describing your CT scan, you cannot first describe, you have to describe in all directions. Remember, describe superiorly, inferiorly, anteriorly, posteriorly, medially, and laterally. Always remember, as soon as you see the lesion, and if all the cuts aren't available, you should ask for them. Now, it's very nicely shown all the cuts in a series, but sometimes in an exam, they'll just give you some 2 cuts. So you need to know. So you have to go to the normal part on top, normal part below, medially, laterally. Okay, so describe a CT scan in all of these dimensions. Your lesion has to be described. Then you can talk about involvement of things like thyroid cartilage. You have to talk about exolaryngeal spread if it's present or no. And exolaryngeal does not always mean only thyroid cartilage involvement. Okay. And if you find any of these things, so what you have to know is all your T stages, T1, T2, T3, T4. What forms part of T1, T2, T3, T4, N1 to N3 has to be described in your CT scan. Okay, whatever is required for any CT scan, even oral cavity. If you know what is required in what is T1, T2, T3, T4, those are the points that have to count, because this is a modality to help you stage the disease. Okay, so see that all those words which are there in your T1 to T4, you say those words in your CT scan. So T4B has prevertebral fascia, has carotid involvement. You have to say that it's not there or there. Okay, so that's a good way to report. Report it in all directions and all dimensions, up, down, laterally, medially, and then think of everything that is there in your TN staging and see that you look at that in your CT scan and say that. Okay, so that's the way you have to report your CT scan.
So how do you stage this as?
So T4B, N2B.
Why are there multiple nodes? Why did you stage this as N2B?
Multiple nodes on the left side.
Okay.
Why do you stage it as T4B?
So prevertebral fascia, as in
Okay.
involvement of the prevertebral fascia. T4B will be involvement of prevertebral fascia encasing the carotids.
Well, they are separate things, prevertebral fascia and encasing the carotids. Here it's certainly abutting the carotid, but you don't quite get more than 270 degree or even more than 180 degree abutment. And generally the radiological correlate of encircling or involvement of carotid would be 270 degree encasement. So here you see it medial to the carotid, you see it pushing the carotid out.
Yes, sir.
Yes, there are also nodes on the lateral surface. So you could say, I mean, you could say, but you'll have to qualify to me. You could say that I see tumor on the medial surface of the carotid artery close to the bifurcation, and I also see some nodes on lateral to it, and it seems encircling the carotid. Basically, the moment you say T4B, you are condemning the patient to non-curative treatment on most occasions.
Yes.
Something you have to say very carefully and you have to justify. I like the justification, but it could be a little bit more, as I said, yes.
So I think I'm going to agree with Dr. Thakkar on this and tell you that, see, prevertebral fascia involvement is not something that you should easily jump to in a CT scan. Okay, because of the proximity of the posterior pharyngeal wall and the lateral part of the piliform sinus to the prevertebral fascia. Even if you have a small bulge on a CT scan, you will feel that the prevertebral fascia. So you can see this little black line which seems to have got obliterated. The good thing to do is, one, to have your clinical examination with you. If it's a freely mobile larynx, you have crepitus, then you have to think twice before thinking whether this is prevertebral fascia involvement or no. And two is, you may be able to use an MRI. So
Yes.
Sometimes you can use an MRI scan to make out the exact layer and to find out, but that also sometimes is not helpful. So I think you have to be very, very careful, because your treatment plan completely changes. So anytime you have a patient where you suspect prevertebral fascia, one, you have to correlate it clinically, and two, you may add in an MRI to try and see if there is actual involvement of the prevertebral muscles and the fascia. Okay. Okay, so let's say that the MRI said that there was no prevertebral fascia. It's just a pouting out. Okay, and there's good mobile larynx. Okay, there's good crepitus. So now what will your staging be?
T4A.
Okay, so great. So T4A, N2B, M0. What's your plan for this patient?
T4A, N2B, M0. We have to go for a surgical management as thyroid cartilage is disrupted. So before taking up for surgery, we have to assess his performance status, his lung pulmonary functions, and then
why would you want to assess pulmonary function in this patient? I mean, assess anybody's pulmonary function. There's no worry in assessing, but any particular reason in this patient you want to assess his pulmonary function? I can guarantee you after the surgery, he's going to have better pulmonary function.
Because his.
Why are you so worried about pulmonary function?
You can say that that this patient may have aspirated and may have had
aspiration because the pooling of saliva was there. That's why.
So you want to assess it before surgery?
Yes.
Okay.
Aspiration.
What Dr. Gauri is saying is that if you were contemplating a partial laryngectomy, you'd be very, very worried because it could make the patient worse. If you're doing the total laryngectomy, then obviously, on the long run, it's something that's going to sort the patient's aspiration, and the patient would get better. Okay. So Dr. Gauri wants to know how you will treat your patient. So we'll have to look at more detailed surgery.
Surgical, we would like to do a total laryngectomy plus pharyngectomy with bilateral node dissection with
Don't be worried, you're saying absolutely that sometimes the easiest answers you feel something is wrong, but nothing is wrong. You're absolutely right. Go ahead.
Total laryngectomy plus pharyngectomy plus bilateral node dissection with permanent tracheostomy, and for the pharynx gastric pull-up.
Oh, you straight do a gastric pull-up in this patient?
Ma'am, if the lumen, if we have to check for the length, if on a stretchable, if it is 2.5 centimeter, if it is less than 2.5 centimeter, then we might have to do
what do you want to stretch? You want to stretch the pyriform sinus?
No, ma'am, the pharynx.
How do you want to stretch that?
Ma'am, the stretched pharyngeal, if it is less than 2.5 centimeter post-surgery.
Then you will do a gastric pull-up. I'm a little confused. When do you do a gastric pull-up?
When we have done a pharyngectomy.
In any pharyngectomy, you will do a gastric pull-up.
Dr. Quresh, do you have any other options? Is it a total pharyngectomy always or any other option?
So when do you do which reconstruction? So gastric pull-up is a type of reconstruction. It's an extremely morbid procedure. Gastric pull-up. I don't remember, we hardly do it anymore, in fact.
Suresh, what she's asking is what type of a defect would you have? What would be the extent of pharyngectomy that you would do, and what would be the lower limit of your pharyngectomy?
Yes, it will be the esophagus. As in up to the cervical esophagus, we'll do the lower extent will be till there.
Okay.
So we can understand that you were not prepared for this because you were prepared for a T4B disease, and you were prepared for a discussion which went down the road of how to best treat someone who is T4B and what options are applicable then. So Dr. Gauri's changed it to T4A. Now you need to tell us how you need to move forward and plan your operation. And if this was T4A, you would obviously do a wide local resection. All the things that you said about the operation are true. You would also traditionally do at least a hemithyroidectomy for every patient who has a pyriform sinus or a cancer. And with regard to reconstruction, your options are: number one, to do a primary closure; number two, to do a partial pharyngeal augmentation or a patch pharyngoplasty, as we tend to call it; and number three, to do a total pharyngectomy, and then of course to do a full replacement. So we have no problems if you say that you're not prepared to or not fully prepared with this answer. But if you have any thoughts, we are happy to hear them.
So I'm just confused regarding the reconstruction.
Right. That's a good thing to say. I think that's what initially someone said, that you're confused regarding the reconstruction is a good thing to say. So, Kuresh, Dr. Thakkar, do you want to go ahead or should I?
No, please do, please do.
Okay. So, Kuresh, the thing is that it all depends upon how much of the pharynx you remove. Okay, so if you remove just a little bit of the pharynx, then as Dr. Thakkar said, you'll be able to resuture back the pharynx and you do a primary closure. So there are two things. One is how much of the posterior pharyngeal wall you remove, and two is how low you remove. So if you have a circumferential defect versus just a partial defect, if you have a circumferential defect, then you have two options for reconstruction. There are more options, but generally two options. Either you do a free jejunal transfer or you do a free ALT. These are the two commonest options. But if you can't get a lower limit, then the last option would be a gastric pull-up. Okay. So gastric pull-up has to be kept as the absolute last option. Or if you want to remove the esophagus for any skip malignancies or for anything else, then you can think about gastric pull-up. Okay. For that is when you have a circumferential. I hope you understand what I mean by circumferential. That means you have no pharyngeal mucosa remaining. Okay, at any one point or at a small distance, no pharyngeal mucosa remaining. Okay, so that's your circumferential defect. If you have a partial defect, but you can't, as you said, 2.5 centimeters, you were saying that very nicely. So you want to see if you have 2.5 centimeters, that's just a and nobody knows actually where this 2.5 has come from. 2.5, some say 3, but if you feel that it's closing well, then you do a primary closure. But if you feel your closure is very tight, then you have to augment only one wall of the pharynx. Okay, and that augmentation again has multiple things that you can do, multiple flaps that you can use. You can use a free radial, you can use a free ALT flap, or you can use a PMMC. Okay. So it will depend on whether it is a circumferential defect or no. So generally this kind of cancers which you have, your pyriform sinus cancers, if it's not going down to the postcricoid, you will not have a circumferential defect unless it's also involving the posterior pharyngeal wall, which is why the direct laryngoscopy is extremely important. Okay. If you have the postcricoid cancers, or if you have pharyngeal cancer that is going low down into the cricopharynx or into the esophagus, then you will have a circumferential defect and you will have to do circumferential reconstruction. Okay. Just last question from my side. Would you put in a PEP or no in this patient?
Sorry, ma'am.
Would you put in a tracheoesophageal prosthesis?
Yes, ma'am.
Okay. That's all from my side.
Oh, very good.
Is your treatment complete?
So this is a surgical.
Yeah, when we ask about treatment, you should be able to say one sentence everything together, right?
Yes, sir.
Yeah. So what do you do further?
Then adjuvant RT, sir.
RT or chemo RT? Which one?
So RT, sir. Adjuvant radiation.
When do you give chemo RT?
So if there is extranodal spread, then we would like to add chemotherapy to the radiation.
Better to say the answer saying that adjuvant treatment, either radiation or chemo radiation. That would be the better answer, depending on the final histopathology.
Okay, sir.
So I think we are done with our 60 minutes. I invite our examiners to kindly give their valuation of the students, both on their knowledge as well as their communication skills, which comes handy in such clinical discussions. We'll start with Dr. Thakkar and then to Dr. Gauri and then to Dr. Chandrasekhar.
Certainly, I would have no hesitation in saying that you clear the bar. But having said that, I won't quite say that you clear the bar with flying colors for the obvious reasons that you didn't quite do very well with the examination aspects in the first case. And Oftentimes, that is an area which is an area wherein you can't quite afford to make a mistake when it comes to clinical examination. So that was one thing. Beyond that, I think in general you answered well. Both cases, you were prepared. I understand that you're both second year, so obviously there's limits to what we can expect from you. So in general, I would say quite happy with both of you. I would hope and expect you would make more progress as you go along, for sure.
Yes.
Thank you.
Sure.
And being aware of where you lack, which is of course the most important thing to make progress.
Definitely, sir.
Dr. Gauri.
Yeah, so I would also agree with Dr. Thakkar. I would think that you'll pass your exam, but I think we haven't even discussed, we didn't have the time to discuss a whole lot of evidence, and I'm not aware of, you have to have knowledge. So you have to know when you're saying for T4, you have to do surgery. I would have liked to ask you why, what is the evidence? And in an exam, we will definitely ask you. So you need to know evidence for a lot of things. So what we discussed today was just basic clinical discussion, and we could have gone on to evidence, but I think you'll have to be much stronger in your history and your clinical examination, and really that comes from your clinics. In clinics, we tend to just put up the CT scan of the patient, and because we know that this patient has hypopharyngeal cancer, we work in tertiary cancer centers, so we put up that scan, and we miss that step of history and examination, and we miss a lot. And I say this to my residents all the time, that because we are all working in tertiary cancer centers, we miss that step. And I think if you do it more in your clinics, take history, take a limited history if you can't take everything, but trying to understand how much time of dysphagia, all of these things make a big difference eventually. Do your clinical examination correctly. You saw how laryngeal crepitus is so important for us to know if prevertebral fascia is involved or not. So do it in each of your patients. And in another year, study and do it in each of your patients, history, examination. And I think in another year, you all will be absolutely fine and ready for your examinations.
Yeah, I do agree with both Dr. Thakkar as well as Gauri. So basically, the most important thing in the OPD is clinical examination history. I always say my residents, like if you hear proper history, 90% of the diagnosis is there in the history itself. Diagnosis, of course, for the staging, yes, your fingers do wonder. Sometimes, for example, the oropharyngeal lesion, which is near the base tongue or the tonsil, or this kind of situation where there is a posterior pharyngeal extension of the pyriform fossa. CT scan or MRI really overestimates the issue. So once you clinically examine, you do understand that there is only a kissing effect of the tumor rather than real involvement. So don't never ever miss the examination part, because it gives, see, whenever you are not really sure of particular structures, that particular structure only we should be able to say in the imaging, rather than simply believing only the imaging. So if you really look at this kind of imaging, you label the patient as T4B and label the patient as palliative treatment options. So we should always try to keep the clinical skills, which are obviously there in the OPD. So never ever forget. Otherwise, you have done really good. So there is no doubt passing is not an issue, but one should be able to take proper judgment as far as the patient treatment is concerned. So all the best for you.
Thank you, sir.
Thank you, sir.
We thank both the examinees for their participation till now. Thank you, Dr. Thakkar and Dr. Chandrasekhar. And we request you to stay till the end in case we have some questions for the Q&A. Dr. Toprani, any comments, or should we go ahead with the expert talk?
No, just rightly as Dr. Gauri told, that students have to be prepared with evidence when they are asked for a particular management issue. For example, a role of neoadjuvant chemotherapy or chemoradiation, or the role of when do you give adjuvant chemoradiation and all those things. That evidence has to be there and they have to back their answers with evidence. That part was, because of lack of time, was not discussed today. But in the examination, you must be prepared for that. And certain basic clinical things, for example, the grades of dysphagia, the grades of aspiration and all those things, the grades of trismus. These are very commonly asked questions in our examination. And the general surgical oncology candidates need to understand that they are very important and they play a crucial part in ultimate decision making of management of that particular patient. So I think otherwise you have done well being in the second year. I'm sure in the third year you will learn more of clinical acumen from your institute. I think we can go ahead now for the next part.
Thank you. Yeah, we invite Dr. Gauri Pantaved to kindly deliver the expert talk for today. Madam, we are all yours.
Can you see my slides?
Yeah, not full screen yet.
Yeah, I'll just full screen it.
That's great. Please go ahead.
1 second, right? Oh, this some silly thing is coming in the middle. Yeah, okay, yeah. So was really an invigorating discussion. Thank you, Iman and Quresh. So I'm going to be talking about hypopharyngeal cancer, the management and controversies. A lot of this we have discussed. Yeah, but some of this is new and there's going to be a little bit more of evidence in my talk. So hypopharyngeal cancers are rare cancers. They form 3 to 5% of all head and neck cancers. These cancers are actually going down in their incidence, except for certain parts of the country where they are more endemic, like the east of the country, Assam, Meghalaya, you still have high incidence of hypopharyngeal cancers. They are very aggressive cancers. They present in advanced stages, very high incidence of nodal disease, high incidence of distant metastasis, and overall have very poor survival for advanced stages. Now you have 3 anatomic regions of the hypopharynx: the pyriform fossa, which house the most common site of cancer. 60 to 70% of hypopharyngeal cancers will be in the pyriform sinus. Posterior pharyngeal wall cancers form 20 to 25%. Some important things about posterior pharyngeal wall cancers: higher incidence of bilateral nodal involvement, and retropharyngeal nodes are seen in very high percentage. 42% of posterior pharyngeal wall cancers will have retropharyngeal nodes. Post-cricoid cancers are the least common and they're more common in females. Overall, hypopharyngeal cancer is more common in males. Post-cricoid shows female preponderance, is associated, as you know, with Plummer-Vinson syndrome. The important thing to remember is that of the patients who have Plummer-Vinson syndrome, only around 10% will actually develop cancer. So most patients with Plummer-Vinson syndrome don't develop hypopharyngeal cancer. Certain peculiarities of hypopharyngeal cancer: there is a tendency for extensive submucosal spread, high incidence of nodal metastasis. Around 20% patients will have bilateral or contralateral nodal metastasis. Sorry, should I continue?
Yeah, please do.
Okay. And you have high incidence of retropharyngeal nodal involvement. So if anybody asks you what is the specialty of hypopharyngeal cancers, it is these 4 things. These patients also have thyroid gland involvement, and this is commonly seen in cancers which are affecting the pyriform apex, and the tumor comes out from that area. And 15 to 20% of these patients, as Dr. Thakkar said, that's why you have to have a ipsilateral hemithyroidectomy in these patients. Now, submucosal tumor extension has been studied, and this is one of the studies which looked at whole organ serial step sectioning of 57 resected specimens to evaluate the submucosal spread. Is a big thing in hypopharyngeal cancer. Should you take 1 centimeter margin? Should you take 5 centimeter margin? All of that comes because of submucosal spread. Now, submucosal spread is seen commonly in the following order. So the commonest submucosal spread is inferior, followed by lateral, followed by medial, and lastly by superior. So superior submucosal spread is the least common, and it can be seen in this study was seen up to 3.7 centimeters beyond 3.37 millimeters beyond the primary lesion inferiorly. Now they divided submucosal spread into 3 types. The first one is when you have a smooth contour extending submucosally, and this is evident on gross examination. When you are operating the patient, you can make out. The type 2 is when you have islands or finger-like projections of tumor into the submucosa. It's not evident on gross examination. And type 3 is having a skip lesion, which is separate from the main tumor. Now, the good thing that they found, and this has been seen in other studies also, is that the most common type of submucosal spread is type 1, which is evident on gross examination. So we really don't have to be too scared of this submucosal spread. Skip lesions separate from the main tumor that are not second primaries are very, very rare. Now, this is a wonderful paper by Brian O'Sullivan. Now, he wrote about the natural history of patients with squamous cell carcinoma of the hypopharynx, and I'm just going to show you the abstract. Just look at the results. This typifies what a hypopharyngeal cancer patient is. The typical patient is 65 years old, so it occurs in slightly elderly population, male, unemployed and poor. They are heavy drinkers with significant comorbidity, compromising functional status. The tumors are advanced. Over 50% are stage 4 tumors. After curative treatment, 20% had residual disease. Recurrences tended to appear in the first year, and 50% of first recurrences included distant metastasis. Overall, 47% of patients were disease-free at 3 years, but eventually 64% patients died of their cancer. I think this is it's a really wonderful paper to study to get an understanding of hypopharyngeal cancer. It's important to understand that this is a very aggressive disease with poor prognosis, because trying to do heroic treatment in this patient just because something is resectable has to be probably, you have to balance it with this that is written in this results section, that these patients have extremely poor prognosis. Now let's come to the evaluation. History, look at pain, hoarseness, dysphagia, referred otalgia, some other history that we discussed. Look at nodes, exolaryngeal spread, cord mobility. We in Tata Hospital perform direct laryngoscopy in most patients unless we are able to see on a video laryngoscopy, and you map the mucosal extent of disease. And imaging, you have to look for submucosal spread, cartilage involvement, exolaryngeal spread, neck nodes, distant metastasis. I'm going to talk a little bit about endoscopy. It has a very important role for both staging and planning of the treatment. And if you look at the TNM staging, T1, T2, T3, all these three are determined during endoscopy. Okay. So if your endoscopy is not right and it's not done well, you will not be able to stage your patient well. So this is the endoscopy checklist for hypopharyngeal cancers. Look at T size, look at the subside, pyriform sinus, mention medial, lateral, apex, look at pharyngeal wall, look at the post-cricoid, and look at the esophageal mucosa. You can just see the beginning of it because you may not be able to see it unless you do a flexible upper GI scopy. Look at cord and arytenoid mobility. Look at whether this patient has involvement of the larynx or the oropharynx. All of these factors are important not only in staging but in planning your treatment. And for surgical planning, define your superior, inferior, and lateral extent. So this is the endoscopy checklist that needs to be done for every hypopharyngeal cancers. To achieve this, you have to decide whether you will be able to do all of this with just a flexible endoscopy or you need a rigid direct laryngoscopy. If you can get all of this information, then you can go ahead and do a flexible endoscopy. If not, do a direct laryngoscopy. Now let's come to early stage hypopharyngeal cancers, T1, T2, and 0. Of course, you will do organ preservation strategies, either radiation therapy or organ preservation surgery. There is no head-to-head comparison in early hypopharyngeal cancer between surgery versus radiation therapy. So these are your options for treatment. Radical RT, surgery, which is endoscopic, or open partial pharyngectomy. In my book, there is absolutely no role for a per primum patient to undergo an open partial pharyngectomy in today's day and age. Any surgery that you plan for should be endoscopic, and that can be TORS or laser, or if you have TAUS with you. Now let's look at what is the literature on comparison of surgery versus RT. They have similar disease-free survival and overall survival ranging anywhere between 66 to 80%. This is T1, T2, N0 cancers. Please remember, these cancers are rarely seen. You don't find, if you find one cancer, you quickly take a video and you keep of it because so rarely you find T1, T2 pyriform sinus cancers. Now, one thing that you have to remember about surgery, that post-operative radiotherapy in all series that have looked at surgery for pyriform cancers will be required in around 50% of patients who are undergoing surgery, because you cannot have compromised margins in pyriform sinus cancers. One, they are aggressive tumors. Two, they have a tendency of submucosal spread. So you can't have compromised margins. And so there is a very high requirement of postoperative radiotherapy, which is a second modality. Now, here is one of the contemporary results of oncological and functional outcomes of transoral robotic surgery for pyriform sinus cancer. This is a French Getted group study, and this is probably the only this is a retrospective study, but it's a largest study that's available. From 2009 to 2017, 8 French tertiary referral centers analyzed 57 of their patients who underwent transoral robotic surgery for pyriform sinus cancers. Of this, 52 were per primum cases and 5 were salvage. So as you can see, we seem to have a reluctance to do endoscopic surgery for salvage procedures, especially robotic surgery. Safe margins were achieved in 70.2% patients, but they found a higher margin positivity rate in anteriorly placed pyriform sinus tumors. Again, in their series also, adjuvant radiotherapy was given in 54% of patients, but they had some good results. Larynx preservation rate was 96%. They had no tracheostomy dependence, and oral feeding was achieved in 96% of patients. If you look at the survivals after transoral robotic surgery, 2-year overall survival was 84%, 4 years was 66%, and disease-free survival was 74 and 50%. So decent overall survival and disease-free survival in these patients after transoral robotic surgery. Now, here are the criteria to choose surgical resection in T1, T2 hypopharyngeal cancers. And there's a huge amount of criteria that you need to have. One is you have to have endoscopic surgical expertise. There's no role of open surgery in this group of patients. These tumors should be small volume, superficial, in accessible areas. You can't have them low down, or in the case that even Imam said, it's in a post-cricoid area, you cannot do it. You cannot do endoscopic surgery. Lateral or posterior pharyngeal wall lesions are probably the best for endoscopic surgery. Patient should have mobile cord, functional larynx, and preferably no neck nodes. Now, unfortunately, this may not be available in too many patients, and therefore, radiation therapy really, as of today in early hypopharyngeal cancers, in most patients is considered standard therapy. Surgery, if we have to perform, has to be minimally invasive, but remember, greater than 50% of patients will need adjuvant radiotherapy, and your survivals for T1, T2 cancers are going to be around 66 to 80%. Now, let's come to locally advanced hypopharyngeal cancers. T3, T4 node positive cancers are called locally advanced cancers. I'm going to get T4 out of the way. So you have T4A and T4B. For T4A, as we discussed, we would probably go ahead with surgery, do a total laryngectomy with pharyngectomy with bilateral neck dissection and appropriate reconstruction depending upon the defect. There is a very small group of patients and in all probability in hypopharyngeal cancers, we wouldn't think of organ preservation in T4A tumors. For T4B tumors, generally we look at non-surgical options. These are extremely poor prognosis patients. We should not try to do heroic surgery in hypopharyngeal cancers, especially in T4B. And the most common surgical options are chemoradiation, chemotherapy, or radiation. Now, the area of debate actually in hypopharyngeal cancers is in T3 node positive functional larynx. Now, here is the debate. There are 3 options here. In this group of patients, T3 node positive, you can do either upfront surgery with adjuvant chemoradiation, upfront NACT for all followed by definitive treatment, or chemoradiation in this patient. Okay. Now, the reason why I have given these 3 and say there is a debate is because, one, there's a rare cancer. Large randomized controlled trials are not feasible or available for us to know whether surgery is a better option in this patients or chemoradiation is a better option. Most evidence comes from retrospective studies, and we have extrapolated from organ preservation strategies in laryngeal cancers. Now, the biology of laryngeal cancers, we must understand, is very, very different from hypopharyngeal cancer. So we are unsure whether this extrapolation that we have done on organ preservation strategies applies to hypopharyngeal cancers or not. Now, we have only one randomized trial looking at organ preservation in hypopharyngeal cancers. This is the very famous EORTC trial, which was in the previous century, it was published. Now, what happened in this trial was locally advanced resectable hypopharyngeal cancers were randomized one arm to upfront surgery, and this was in 99 patients. That's total laryngectomy with radiation. The other arm underwent induction chemotherapy. Now, patients who had complete response then underwent definitive radiation. And they found that there was no difference in survival between this surgery and the induction chemotherapy arm. Now, after this trial, really not many people were very happy in trying to do organ preservation for hypopharyngeal cancer, and that was because this actual sample size, which was supposed to be there for this trial, was 270, but accrual was stopped midway. Only patients with complete response on induction chemotherapy. So they really bio-selected their patients very well, and only those patients underwent radiation. All poor responders. In fact, a large number of patients on the induction, nearly 40% of patients, even on the induction chemotherapy arm, actually received surgery. Now, the trial that really got hypopharyngeal cancer into organ preservation domain was the Rtog trial. Now, this trial, as we all know, defined the role of chemoradiation in organ preservation. It was not designed to look at survival, only to look at organ preservation. Two things: it did not have a surgery arm, and two, it had no hypopharyngeal cancer. It had only laryngeal cancer. But after this, most people moved to use organ preservation, and chemoradiation in hypopharyngeal cancers increased because the morbidity of doing surgery in hypopharyngeal cancers is even worse than laryngeal cancers, because more often than not, you require some sort of reconstruction, you have higher rates and incidence of surgical morbidity, and eventually these patients don't do as well as laryngeal cancers. So everyone started to wonder whether you wanted to actually do these morbid surgeries, and therefore chemoradiation started coming into hypopharyngeal cancers. Please remember, we still don't have any trial to say chemoradiation is better than surgery as far as survival is concerned, or even organ preservation is concerned. But because of all of these reasons that I said that is a problem with doing surgery in hypopharyngeal cancer, organ preservation has now become an accepted treatment option for locally advanced hypopharyngeal cancers, which one have a functional larynx and two are moderately locally advanced. Now, here is some data after people started giving chemoradiation. I'm going to show you some data. This is not randomized data. Here is a prospective data collection, 166 patients comparing surgery plus RT versus CT-RT. And what you find is seems to be a better survival for patients with surgery. However, this is not statistically significant. Very many retrospective analyses are now available, which look at comparison of oncological and functional outcomes between initial surgery versus chemoradiation. Again, this is not level 1 evidence. These are only retrospective n number of biases. Most of the times you'll see larynx preservation rates with chemoradiation are between 70 to 90%, but again, survivals are poor, between 40 to 60%, depending upon within locally advanced hypopharyngeal cancer, what is your stage? This is our data of 501 patients. None of these patients underwent surgery. All of these patients underwent either radiation, chemoradiation, or neoadjuvant. Majority of patients were stage 3, stage 4 cancers. Again, we had not very great survivals, 47% survival at 3 years and 40% survival at 3 years. And this is one thing that is really stark, that if you have stage 4 cancer and you have treated with a non-surgical modality, then you will have very, very poor disease-free survival and overall survival. You can see how. So non-surgical modalities, that's why, are restricted for a little better stage of cancer. Now, because of all of this controversy between all of this, if you look at NCCN guidelines, you will find that they give all these options. They give you NACT, they give you surgery, they give you chemoradiation, and they say patient can go on to a clinical trial. Now, what is the role of induction chemotherapy? Now, one of the subsites within the head and neck, besides probably nasopharynx, where you do use a good bit of induction chemotherapy, is the hypopharynx. That's because the only trial that we have on organ preservation in hypopharyngeal cancers used induction chemotherapy. So induction chemotherapy can be used to select candidates which are likely to do well with organ preservation strategies. And response to induction chemotherapy acts as an indication for likely response to radiation. This is our article which we published on neoadjuvant chemotherapy in advanced hypopharyngeal cancer. Retrospective review of 59 patients with locally advanced CA hypopharynx. Neoadjuvant chemotherapy was given for 2 indications. One is to bioselect patients. So the problem that we are having is we have advanced cancer. We don't know whether we want to conserve this patient because these group of patients may not do well. Their prognosis is not good. So if they respond to neoadjuvant chemotherapy, there's a higher chance that we'll be able to do organ conservation. And in borderline resectable patients to help make them operable, we found that there was an organ preservation rate of 70% with the use of induction and a resectability achieved in 30% patients. So for the future, we need a trial with head-on comparison between surgery plus adjuvant chemotherapy versus chemoradiation. And this is our proposed study where we are going to do exactly that. We are looking at chemoradiation, and the other arm we are going to bioselect using neoadjuvant chemotherapy. But till then, I'm going to conclude by giving you the summary of management of advanced hypopharyngeal cancer. There has been a paradigm shift in the management as a result of organ preservation protocols. And even though they have not been tried out in a randomized way against surgery in hypopharyngeal cancers, most patients with moderately advanced hypopharyngeal cancer will undergo if they have a functional larynx. It's mainly for stage 3 tumors with functional larynx. So T1, T2, N1 or T3, N0 to N2. This is the group of patients with a functional larynx that's ideally suited for organ preservation protocols. T4 disease with cartilage erosions or T3 patients with dysfunctional larynx should undergo surgery with the appropriate adjuvant therapy. For select T4 patients, and this is really a little controversial, but yes, there is something called select T4, that's where you have exolaryngeal spread without cartilage erosion. You may, in this very, very small group of patients, consider organ conservation protocols. Thank you very much. I'll be happy to take any questions if there are any.
Thank you, Dr. Pantwede, for that excellent and lucid talk on the topic. What I'll do is I'll bring up the Q&A session and invite all our 2 examiners, also Dr. Thakur and Dr. Chandrasekhar. What I've done is I've selected the questions from the chat and posted them to specific examiners, but I invite the other examiners to contribute as well. So the first question, I think Dr. Kauri already covered in her talk, which is the NACT. So I'll post this to Dr. Thakur. Sir, what are your contemporary indications for neoadjuvant chemotherapy?
So thank you there. Very difficult question. Not sure we have very clear answers on that one. In general, we remain very careful with concurrent chemoradiation for hypopharyngeal cancers because both the amount of morbidity that it entails and long-term morbidity plus short-term morbidity that it entails, and the reality that post chemoradiation for a significant hypopharyngeal cancer, salvage is often not a very easy option at all. So I mean, really, salvage hardly ever is undertaken. So NACT remains an option in many situations. The problem with NACT is that if there's a non-responder, then of course disease will progress in that situation, and we can easily anticipate even with triple drug NACT that 40% patients will be non-responders. So our general policy remains that if we have someone who's a borderline resectable patient, then he goes down the road of NACT, and that about is the only indication for NACT in our practice today.
Any inputs from the other examiners?
See, in our practice, at least the hypopharyngeal malignancy, if it is normal functional larynx with T4 disease, extralaryngeal extension without cartilage involvement, or actually I put across one of the case with a huge neck nodal mass with a small primary. it was very huge in the sense skin was involved and there was a rupture of the skin and it was oozing. So that kind of N3 disease with fixed nodes with gross extranodal extension, where there is a possibility of probably not able to give proper dose of radiation. So that would be one of the indication, N3 with extensive disease, as well as T4A disease, or a borderline kind of T4B if you suspect clinically, radiologically, and make it operable or make it, reduce the size, downstage it so that we'll be able to give proper CTRT or do surgery accordingly. So in nutshell, T4A without any cartilage invasion, and T4B, borderline T4B, and huge neck nodes where there is a possibility of difficult to give radiation. Those are the indications we practice in our. And one more indication, soft indication, which probably would not be able to say, if you do a PET scan and there is some kind of doubtful nodule in the lung or somewhere else, where you can't really get FNAC or get a biopsy done. So in that case, our intent is kind of palliative CT bar NACT and assess the response again to see that if that lung nodule responds to your chemotherapy, thinking that then it would be a malignant lesion, and then we consider directly the patient as palliative. Or if it's a kind of stable disease and you feel like it is non-metastatic at the end of 2 cycles, then probably we'll consider that kind of patient for a proper radical treatment.
Madam, any inputs from you outside trial settings? What would be your clinical practice as to the NACT?
So I would agree with what both of them have said. I would also use NACT in borderline resectable lesions. I'm not very sure if I'll use them. If, as he said, if you have a small primary and a large node, that's fine. But otherwise, I would use them if you have patients in which I'm going to have to resect the tongue base. And I wouldn't like to do that unless I know whether this is, first of all, a good lesion and whether I would be able to get margins on it. So one is definitely for borderline resectable. But I think in certain cases also to know whether this is a good, whether this patient should undergo organ preservation versus not. So if you have exolaryngeal disease that's not involving the thyroid cartilage, that's another indication in which I use neoadjuvant chemotherapy. And if this responds then, and the patient has a functional larynx, not very extensive nodal disease, then this group of patients will go for organ preservation. See, the morbidity of chemoradiation is very high, but the morbidity of surgery is not less either. So I think when we have to decide, and induction chemotherapy just actually adds to the morbidity. So it's a really tough tightrope walk that you have to do when you have locally advanced hypopharyngeal cancers. Bad prognosis, poor nutrition, patients can't tolerate treatment, all aggressive treatments are extremely surgery, radiation, chemotherapy. So it's a real tightrope walk with you. But that's the 2 indications. One is for bioselection, which I use less commonly. More commonly, I'll use it for borderline resective.
Thank you, examiners. Second question I'll pose to Dr. Chandrasekhar Rao. Salvage surgeries, what would be the patients who are selected for it? What would be the timing for it, and the issues that come with salvage surgeries?
It's really tough question because it's not like the laryngeal malignancy where you straight away do laryngectomy, because if it is endolaryngeal disease, straight away do laryngectomy if there is a residual disease. Most of the hypopharyngeal malignancies, when we consider for CTRT, when there is a residual disease, majority of the times you will not be able to basically get a partial laryngectomy. If you can get a partial pharyngectomy, a total laryngectomy, if that is the case, we'll be able to do it and do a proper patch pharyngoplasty. But as pointed out properly, the patient selection is very important. We need to look at the nutrition status as well as the performance status. So accordingly, we should really take a call. It has to be a tailor-made call. It's not so easy to say that blanketly saying that this patient requires a proper salvage surgery. So when there is a residual disease and if it is operable, we go ahead with the surgery. And the timing wise, we generally assess after the CTRT at the end of 6 weeks, we assess the response of the CTRT or the non-surgical treatment. Then if you find that clinically there is a disease, then we get the appropriate imaging and go ahead with the surgery. 6 to 8 weeks is the ideal period, but the biggest problem nowadays is we do the PET scan at the end of 10 weeks, because before that, if you do it, it will be unlikely that you get good information. So, but as soon as possible, 6 to 10 weeks, I think probably is the timing. And beyond that, it becomes really tough for the surgeon because lots of fibrosis sets in and healing issues also will set in. So best would be 6 to 10 weeks. And if there is a case for salvage. And issues are many, starting from, as I said, the patient nutrition, performance status, preoperative itself. And a good number of patients will have some amount of lung dysfunction because of the CTRT, which leads to some amount of microaspiration. And the other issue, I mean, the per-op or intra-op, we will be able to, I mean, we will not be able to judge the margins properly because already patient underwent some kind of treatment like CTRT or RT. So it's very difficult to assess the margins clinically, and sometimes we need to rely on a frozen section. And the other issue is reconstruction. So we need to really consider for a good amount of the pharyngeal lumen has to be set in, so that we need to properly consider for reconstruction, whether it is a patch pharyngoplasty or a total pharyngeal reconstruction. So depending on the remaining mucosa which is present on the posterior pharyngeal wall. And whatever said and done, whatever surgery we do it, we around at least 30 to 40% of the individuals will have some amount of complications, wound complications, and pharyngocutaneous fistula. So it's quite high, especially if it is hypopharyngeal disease and where the patient received CTRT. So the pharyngocutaneous fistula is very high, around 30 to 40% of the individuals. In spite of doing a proper reconstruction, either in the form of free flap or a pectoralis major muscular cutaneous flap, so there would be complications in terms of pharyngocutaneous fistula as well as wound healing. So lots of challenges. It's not so easy. As I said, like laryngectomy is quite simple, but if there is a pharyngeal disease and we can do a salvage laryngectomy and pharyngectomy, it becomes really tough.
Dr. Thakkar and Dr. Pantwell.
Well, generally agree with the difficulties. As was said by Dr. Gaure in her talk, she sort of put up a lovely paper which talked about the natural history of hypopharyngeal cancer, and that really tells you that a very large proportion, 45%, are going to recur in the first 12 to 18 months and often with distant mets. And really, there's no way you're even going to consider salvage surgery unless you have had the best workup with regard to a PET CT. That's number one. Number two, very careful with regard to extrapharyngeal spread, which is usual in these situations. Very careful with regard to lower extranodal disease in the level 4 kind of situation, which is very usual in these patients. Very careful with tracheoesophageal groove involvement, which is again fairly frequent if the disease is going downstairs. And sometimes it's sensible to not get involved with surgical treatment in these situations because natural history being so aggressive, I would certainly get involved with a T3 kind of lesion, which is recurring because you have a reasonable chance. But any of these things I talked about, I would be very careful about getting involved.
Madam, any inputs? Shall be good.
Yeah, so just one quick comment, and I think Dr. Thakkar alluded to it, and that's of the Teo Groove Involvement. I've always seen that in the salvage surgeries where you have exolaryngeal disease, it's always safer to not open up the entire neck and raise all the flaps, but go on from one side in that disease and see if you're getting that plane with the prevertebral fascia. So I think that's one tip that I'd like to give for salvage surgeries, that you not open up the entire apron flap, and you know, because many a times you'll be stuck with the disease reaching into the prevertebral fascia. The second thing about patient selection is one thing you have to understand, that many of these hypopharyngeal cancers are these frail looking ladies. And I think you have to look at good parameters. Just because the patient looks frail, and they probably have been frail because that's how is the profile of Plummer-Vinson syndrome and patients. They're frail, thin ladies, but they sometimes, if they have a small volume disease, do well. So patient selection should have better criteria, and there are many scales that are available, and you should apply one of these scales before you decide that the patient is not fit. Many of them look very frail. Timing wise, I feel whenever you have a recurrence, you have to operate. We don't have too much time to wait for anything in hypopharyngeal cancers. If it is operable, this patient should be operated. If you have decided that you want to operate, if you have a very quick recurrence, it's actually a residual disease. As Dr. Thakkar said, you may think of not operating this patient at all. But if you have decided, operate whenever. These progress very fast. Issues, I agree with what Dr. Chandrasekhar said, and it's not an easy surgery. It's complicated with everything, and all of this needs to be counseled for the patient. Those are my views.
Third question I'll pose to Dr. Pantwede first. Transolar laser surgery versus TORS. Is it only preference and availability, or is there more to it to prefer one over the other in certain situations?
So I must say that I have performed only one TORS for a hypopharyngeal cancer. I have performed maybe 10 laryngeal resections for pure hypopharyngeal squamous cancer. Some of them have also been in the salvage setting, which is not a good setting to do endoscopic surgery. Now, the problem that I have with TORS is that sometimes your reach is not available in hypopharyngeal cancers. You're not able to, the instruments are such that you're not able to reach the lower parts of the hypopharynx. So if it is in the higher parts of the hypopharynx, my preference will always be robotic surgery because I find that the way the robot moves and the angle and the visualization is fantastic. So if it is in the higher part, upper superior part of the hypopharynx, I would go for robotic surgery. If I have something that's in the pyriform sinus or something lower down, I would go in with laser surgery. So that's the way I would choose. I must say these are very far and few, unlike laryngeal cancers. I haven't done many robotic surgeries with pyriform sinus, but I find it easier to do something that's almost coming closer to the supraglottis with robotic surgery. And is availability is an issue, but I think more than availability, I think you have to have very good training in oncology. You have to have a good experience in training in managing hypopharyngeal cancers. It's not a matter of just resection as far as this is concerned. So it is not just having the robot or the laser. You have to be a good oncologist who has had good experience in managing. Otherwise, you'll do it for the wrong group of patients.
Any inputs from Dr. Thakkar and Dr. Chandrasekhar?
Well, we have a fair amount of experience with both laser and robotics. We've been involved with that for many years now. But the hypopharynx is not quite an area where you walk in with unthinkingly. There are major access issues, and Gauri referred to that. It's only the upper hypopharynx that you can get reasonable access. The lower down you go down, the less confidence you have. It's not the taking the tumor, it's the lower margin of the tumor wherein you invariably end up with having issues with regarding to appropriate margin. And of course, it's the depth of the tumor, because this is only mucosa and submucosa, and you can't quite get an excision with complete depth. So you always have to ask yourself the question that, is this the right patient? And generally, we tend to get involved only with patients with tumors which are very superficial and which are very high. A couple a year is what we get involved with. Now, I have become a little bit more, I moved out of TORS towards laser a little bit in the recent past, because I have realized that the robot with its arms, especially with its current arms, which are a little bit thicker than the previous arms that we used to have, there are access issues in getting down. The lower down you are, the more difficult it is to access. So you have to have patients with good access. The series that you talk about are series which have selected patients, depends on access. And of course, the most important thing with any endoscopic transoral thing is that you should have access. If there is limited access, laser is a little bit better than TORS, because though it takes much longer, it's it allows you to work with less space. That's my personal experience and thought. I am often also quite happy to just do a partial hypopharyngeal resection rather than do an endoscopic resection if there's any suspicion of deep extension. So partial laryngopharyngeal partial laryngopharyngectomy, suprachiral partial laryngopharyngectomy is something we do for high pyriform sinus lesions. But very important to do good case selection, and of course you have to have the appropriate expertise to do it. You can't quite ask someone else to do this operation. Everybody has to choose their own operations here. They have to see if they can make it happen. I can't quite say, why don't you get this done? If you can do it, do it.
Our last question is not on the chat. It's a common question we post on these webinars, and that's the last question on the post-op management, because this is where we find a little bit variation in between the experts. So the question for today is antimicrobial prophylaxis, drains, and rehabilitation. In short, what is the approach? I'll start with Dr. Chandrasekhar here, and then maybe the others can chip in.
See, as such, antimicrobial prophylaxis, hospitals, because it depends on the institute where you're working. So we do consider for our hospital third generation cephalosporins and the Metrogyl anaerobic antibiotics. So we give in salvage sitting, we give at least for 3 days. If it is a primary, we give only for 24 hours. And for the drains, again, the most important thing as far as the laryngectomy or pharyngectomy success is concerned, I think it's mainly because of the suction drains. Because of the suction drains only, the success rate has increased and the complications have come down, wound complications, wound infection, everything has come down, as well as the pharyngocutaneous fistulas. And also, if there is a minimal leak, the chyle leak, and those issues also can be really taken care of because of the suction drains. So we generally use suction drains, which encompasses both necks, wherever we operate, whichever area is operated. So we need to basically place the suction drain in the particular area so that the drain, there won't be any collection, as well as the tissue will get collapsed and skin will nicely drape onto the pharyngeal closure. And speech rehabilitation across all, except if it is a like a circumferential disease where we do a reconstruction in terms of ALT or a jejunal flap or a gastric pull-up. Any other patient, we try to give the TEP here in our institute. So puncture and then the process is done in there. In spite of if it is salvage or the primary, we try to give it in the surgery itself. We don't do it as a secondary procedure unless there is a circumferential defect. So that is our policy here. And the speech rehabilitation starts from, generally, of course, the rehabilitation starts before surgery itself, in the sense we counsel in such a way that the patient will understand better. And once the Rice tube is, or the NG tube is removed, after a week or so, we start counseling about the speech rehabilitation in our hospital. And the swallowing, of course, nothing much to say about this. And once the wound heals well, obviously they'll be able to swallow. Only problem is in circumferential defects, especially if you use cutaneous flap, there would be some amount of stagnation of food initially, and slowly they'll be able to accommodate as well as just for that. So, and in our practice, at least the jejunal flaps, we stopped using it. See, I got trained from Amrita, we were using initially, and there are lots of complications. So either in male patient, we generally use pectoralis major tube flap or ALT or radial forum, depending on the defect. We stopped using the mucosal flaps. And of course, if the disease is extending into the thorax, we do gastric pull-up. So without much doubt. So I think that's the.
Anything to add, Dr. Gauri and Dr. Thakur?
Did you ask me or Dr.
Yeah.
Oh, sorry.
So
quickly, I'll go through each one of them. I overall agree with what Dr. Chandrasekhar has said. Just for antimicrobial prophylaxis, we also used to give 1 a day, but we just completed a large randomized trial of 500 patients, comparing 1 day versus 5 day in clean contaminated cases, and the 5 day was far superior. So I don't know if it is any patient, but we have now, because of our randomized trials, we have moved to giving 5 days of antimicrobial prophylaxis. I use the same agents that he does. We will put in drains, and I'm not going to that. Dr. Rao just spoke about it. Speech, again, very proactive in using the TEP. So if you have party wall, and sometimes even if you have a circumferential defect, you can have a party wall. If you have an intact party wall, we will put in a TEP. That's the only rule. Of course, we have to look at if the patient wants it, if the patient can voice and all the other things. But if you have a party wall between the trachea and the esophagus, we'll put in a TEP. Swallowing rehab, yes, we have a good speech swallowing team, and all our patients post-surgery will have swallowing rehabilitation, even if they have a primary closure. There is difficulty in swallowing rehabilitation for patients who have circumferential defects. We tend to use more of the free jejunum than the anterolateral thigh flap because of some issues with strictures that we find more commonly with the anterolateral thigh flap. But jejunum is a very, very delicate flap, and it does have complications, and it also sometimes has very troublesome peristalsis. So maintaining the TEP after a jejunum sometimes becomes, they have a lot of mucus secretions, and the voice is also quite gurgly. So that's the thing about these 4 points.
Thank you, Dr. Pantwede. I think Dr. Tucker had to leave because of some commitment. So this brings us to the end of the academic discussion for the webinar tonight. I would like to first personally thank Dr. Gauri Pantwede for her talk and her participation as an examiner, and for the clarity with which she has given the residents something to go back to on YouTube and maybe refer to the trials again. Thank Dr. Chandrasekhar for his case capsules, and Dr. Tucker for his great questions and advice for the students. I invite Dr. Toprani to kindly give the vote of thanks for today. And before he does that, I would like to pass on a message from Dr. Sanjay Desai to invite all of you to the West Zone CME of IASO at Indore from 29th to 31st July. He wanted to do this in person, but there's heavy rains in Indore and unfortunately cannot do it. Dr. Toprani.
So I would thank Dr. Chandrasekhar for having great case capsules for discussion. The examinees, the students did well, above average, and I'm sure they will improve as they gain more experience in their training. We had two great examiners in Alok and Gauri, and Gauri did a fantastic job in giving an overview of hypopharyngeal cancer. Thank you, Gauri, for having accepted this at a very short notice. And lastly, I would say that we have a great West Zone conference coming up, ISO conference coming up in Indore, and the dates will be 29, 30, and 31st July. It's a great opportunity for the youngsters, the trainees, and the students to come and learn the basics, the clinical information about common cancers, and there will be a lot of interesting debates and panel discussions, and I'm sure you will benefit from your exam point of view also. There is an opportunity for you to present your papers or posters and interact with the national faculty. With that, I would end this session, and it was a great session, and I'm sure the students would have benefited immensely. Thanks to all the examiners and Dr. Srijan to have conducted this very well. Of course, Dr. Rao for Academic Council.
Thank you, Dr. Toprani. This brings us to the end of today's meeting. The next meeting is on 28th July, 7 p.m. Thursday, and the topic would be neuroendocrine tumors. Good night, and thank you, everyone.
Good night.
Good night.
Thank you very much.
Good night.